Good morning, one and all. I'm Dr. Aaishwariya. Today I'm going to discuss about scaling and road planing, which is an essential procedure for every patient who has to maintain their oral hygiene properly. So what is that today? We'll discuss today. So my contents include introduction, the instruments used for the scaling and route planing, and its classification. What are the principles to be used while doing scaling and route planing? The techniques of scaling and route planing, that is supragingival scaling and subgingival scaling, and the various approaches of the instrumentation. So coming to the definition, the scaling is a process by which the biofilm and the calculus is removed from both supragingival and subgingival tooth surfaces, whereas route planing is the process by which residual embedded calculus and the portions of the cementum are removed from the roots to produce a smooth, hard and clean surface. So coming to the classification of the instruments, the instruments that are to be used for the scaling and route planing procedures are first is periodontal probes and explorers, which are used to detect the calculus or any dental caries from the supragingival and subgingival surfaces. And coming to the main instruments that are scaling and route planing instruments, sickle scalars, scalars, files and ultrasonic scalars, and periodontal endoscope, and the cleaning and polishing instruments. So periodontal probes, these are the main instruments which are used to locate the calculus or biofilm and measure the periodontal pocket depth. So these periodontal probes are used to locate, measure and mark the pockets as well as to determine the course on the individual tooth surfaces. So there are the design of the probe is tapered rod-like instrument which has calibrations on it to measure the periodontal pocket depth and with the millimeters, and which is blunt. If it is very sharp, we will cause damage to the tissue, soft tissue, and it will be a rounded tip. The World Health Organization probe, WHO probe, has a millimeter markings and has a very round ball tip at its end. And furcation areas can be best evaluated with the neighbor's probe, which is curved end, and the shank should be aligned with the long axis of the tooth surface. Coming to the explorers, they are used to locate the subgingival calculus and deposits and caries, and are also used for checking the smoothness of the tooth surface after the scaling procedure. So coming to the scaling and curettage instruments, we have sickle scalars. They are used primarily to remove the supragingival calculus. They have a flat surface and two cutting edges, and sickle scalars are used with the pull stroke, and their shank, we have two types of shanks, that is straight shank and a curved shank. This straight shank is used to do the procedure in the anterior tooth, that is front tooth, and the posterior, the curved shank is used to do the procedure in the posterior tooth, that is there is a curvature present so that the curvature can be adapted easily to the posterior tooth. So coming to the curettes, these are used, the curettes are used for the doing the procedure in the subgingival calculus, to remove the subgingival calculus and root planing, that is the altered cementum is removed, the soft tissue lining of the periodontal pocket. So the curette is finer than the scalars, that is hand scalars, supragingival scalars, because these subgingival scalars have to be inserted deep into the pocket, and there should be no damage to the soft tissue. So these are designed as such with a fineness so that it will cause minimal trauma. So there are two types of curettes. One is a universal curette and the other is area specific or Gracie curettes. So universal curettes are have the cutting edge that may be inserted in most of the areas of the dentition. That is the universal, the name itself tells that this universal curette can be used in any surface of the total oral cavity, that is in every part of the tooth it can be used. The face of the blade is very universal, that is it has 90-degree angle to the lower shank when seen in the cross section from the tip. So coming to the area specific curettes, the name itself tells that there are a set of 7 instruments which are used in a particular area. So those are known as area specific instruments. So we have Gracie 1 to 14, that is each scalar contains of both ends. It is a two-ended instrument. 1, 2, 3 and 4 are used in the anteriors, and 5 and 6 are used for anterior teeth and the premolar. 7, 8, 9, 10 are used for the posterior teeth, facial and lingual side, whereas 11, 12 are used in posterior teeth mesial side, and 13, 14 are used for the posterior teeth distal side. So these are the Gracie curates. This is 5 and 6 for anteriors and premolars. 7 and 8 these are used for the premolars, and these two are used in the posterior tooth. That is why the shank is a bit curved. So we have a recent additions for the Gracie curates, that is 15, 16 and 17, 18. 15, 16 is the modification of 11 and 12. In this 11 and 12, the blade is combined more acutely with the 13 and 14. That is 11 and 12 blade is combined with 13 and 14 shank. And we have one more update, that is 17 and 18. This is the modification of 13 and 14. In this, the terminal shank is elongated 3 mm more angulated, so that the shank provide complete occlusion clearance and the better access for the posterior teeth. Coming to the extended shank curates, these are the modification of the area specific curates. The terminal shank is 3 mm long, allowing the extension into the deeper periodontal pockets, that is more than 5 mm of the pockets, and it has a thin blader so that easy insertion into the periodontal pocket is seen. So these are extended shank curates, and again we have mini bladed curates. These are also an advancement of the Aaishwariya Mini 5 curates. These Mini 5 features are they have a thinner blades, so that we can insert them into the periodontal pockets, deeper periodontal pockets, which and also into the furcations, developmental grooves, line angles, and deep tight facial, lingual and palatal pockets. And Langer and mini Langer curates. The Langer and mini Langer curates are set of 3 curates, that is 5, 6, 11, 12 and 13, 14. The Langer 5, 6 curate adapts into the mesial and distal surfaces of the anterior teeth. The Langer 1 and 2 curate adapts into the mesial and distal surfaces of the mandibular posterior teeth, whereas the 3 and 4 curate into the mesial and distal surfaces of the maxillary posterior teeth. So we have hose scalar. This is used for the to the removal of the ledges of calculus, or ring type of calculus are to be removed with the hose scalars. The blade is inserted deep into the base of the periodontal pocket, so that we have a 2-point contact with the tooth surface, and we can give a pull stroke so that the calculus is removed, ledge of the calculus is removed. So this is the 2-point contact for the crown and the root. It is inserted into the base of the pocket and the calculus is removed. So coming to the chisel scalar, it is designed for mainly for the proximal surfaces of the tooth which are too closely placed, and it is a double-ended instrument with a curved shank at one end and a straight shank on the other. The blades are slightly curved with the 45 degrees angle. So coming to the general principles of instrumentation, the first one is accessibility. The position of the patient and the operator should provide a maximum accessibility for the area of the operation. So how the clinician should be, the position of the clinician is his or her feet should be flat, and the thighs should be parallel to the floor, and the back should be straight with head erect. So this is the operator position. Coming to the patient's position, patient should be in a supine position, and the mouth should be close to the resting elbow of the clinician. So at the elbow position, when the clinician is sitting on the dental stool, the patient's mouth should be at the level of the elbow. For the instrumentation of the maxillary arch, if you are doing treatment on the maxillary arch, the patient should be asked to raise the chin. and for the instrumentation of the mandibular arch, then the chin should be parallel to the floor. So coming to the visibility and illumination and retraction, whenever possible, direct vision or indirect illumination is better seen, and if this is not possible, then the indirect vision is done through the mouth mirror. So this is the indirect position, sorry. So retraction, where the mouth mirror is used for the retraction. Retraction provides visibility, accessibility and illumination. The mouth mirror may be used for the retraction of the cheek and tongue. The index finger is also used for the retraction of the lips. So condition and sharpness of the instruments, this is very important to maintain the sharpness of the instrument. So before doing any procedure, we have to check for the sharpness of the instrument. So if the instruments are sharp, it enhances the tactile sensitivity and allow the clinician to work precisely and efficiently. If there are any dull instruments, then there is an inefficient calculus removal and unnecessary trauma to the soft tissue. So the other main thing is we have to maintain a clean field. So despite of good visibility or illumination or any retraction, there should be a clean field maintenance. So it is done through adequate suction is essential, and blood and debris have to be removed with the cotton or gauze. So to handle an instrument, the instrument stabilization is more important. So we attain instrument stabilization with the instrument grasp and instrument activation. So first we'll deal with the instrument grasp. We have a modified pen grasp. So proper grasp is essential for the precise control of the handling of the instrument. If you are not stabilization of the instrument is not seen, then there is a rolling out of the instrument from the hands is seen. So to maintain that, there is a modified pen grasp. The thumb, we hold the instrument with 3 fingers, that is thumb, index finger and the middle finger. So we catch hold with the thumb and the index finger, whereas the middle finger, pad of the middle finger should be placed on the shank. Then we get a tripod effect. So this is the advantage of the modified pen grasp. And standard pen grasp, that is pen grasp, the middle finger is rests on the shank. And palm and thumb grasp is we use our palm and thumb. This is used when we sharp the instruments or while using a water syringe. So coming for the finger rest, the 4th finger is taken as a finger rest. So that there is a firm fulcrum, it provides a firm fulcrum of the instrument. So we have different finger rests, that is intraoral and extraoral. Intraoral we have conventional, cross arch, opposite arch and finger on finger. In conventional we just the finger rest, this 4th finger is placed on the adjacent tooth beside the working area. Whereas in cross arch, the finger rest is established to the tooth surface on the other side of the arch. If you are doing on the left side, you are taking the finger rest on the right side. So opposite arch is the finger rest is established on the tooth surface on the opposite arch. That is, if you are doing on the maxilla, then the finger rest is taken on the mandibular arch, and vice versa. Finger on finger, the finger rest is established on the index finger or the thumb of the non-operating hand. That is, if your left hand is non-operating hand, then while the right hand 4th finger is kept either on the thumb or the index finger. Then we have extraoral finger rest, that is palm up and palm down. Coming to the instrument activation, until now we have taken about stabilization. Now, how to activate the instrument? So we have adaptations, precise adaptation to avoid trauma of the soft tissue and to ensure the maximum effectiveness of the instrumentation. So we have angulations for that. Angulation while doing scaling and root planing, it should be 45 degrees to 90 degrees angulation. See, the blade angulation, this is tooth and this is the blade of the blade, and this is parallel to the tooth, and this is 45 degrees angulation of the instrument. If it is below 45 or above 90, we can cause a trauma to the tooth or the soft tissue. So this is the correct angulation of the blade angle to the tooth. So during scaling, it should be 45 to 90. If not, burnishing will be. So coming to the strokes, in the instrument activation, we have 3 strokes, that is exploratory stroke, scaling and root planing stroke, and scaling stroke and root planing stroke. Whereas in exploratory stroke, it is a light feeling touch which is used for the probes or the explorers to detect the calculus or the dental caries or biofilm. Whereas a scaling stroke, it is a short powerful stroke, short powerful pull stroke that is used with the bladed instruments for the removal of the supragingival and subgingival calculus. Whereas root planing stroke, it is a light pull stroke that is used for the final smoothing and planing of the root surfaces. Coming to the supragingival scaling technique, we have to adapt the instrument at the base of the pocket or base of the calculus and give a powerful pull stroke with the instrument at the angle of 45 to 90 degrees. Then the ledges of calculus has been removed. Then subgingival calculus is usually harder than the supragingival calculus and is often locked into root irregularities, making it more tenacious and therefore more difficult to remove. Vision is obscured because we have to reach to the root surface. So in addition to the adjacent pocket wall limits, the direction and length of the strokes is seen. The curate is preferred by most of the clinicians for the subgingival calculus removal. So we have to adapt the instrument at the base of the pocket, or we have to give a powerful pull stroke for the subgingival calculus by placing the blade at a 45 to 90 degrees angulation. If it is more than 90 degrees, then you can give a trauma to the soft tissue. If it is less than 45 degrees, then the calculus removal will be not efficient. So coming to the various approaches of the instrumentation, so we have positions to treat the patient. If you are treating for the maxilla and if you are treating for mandible, you have a clinician positions to be attempted. So coming to the maxillary right posterior sextant, then the operator position should be side towards the side of the patient. Then the direct illumination can be used, and visibility is also direct or indirect with the mouth mirror, and the finger rests are extraoral and palm up. In the maxillary right sextant, if you are doing for premolar region facial aspect, the operator should be at the side or back of the patient, and the visibility and illumination are direct, and finger rests are intraoral, palm up, and the fourth finger on the occlusal surface of the adjacent maxillary posterior teeth. Then coming to the maxillary right posterior sextant, in lingual aspect, the operator should be side or in front of the patient, and the finger rests are extraoral and palm up, and the fourth finger are placed on the lateral aspect of the mandible or on the right side of the face. That is extraoral finger rest. Coming to the maxillary right posterior sextant, lingual aspect, the operator position should be in front of the patient. Illumination is direct, and the finger rests are intraoral, palm up, or finger on finger. Maxillary anterior sextant facial aspect surfaces away from the operator. Then you have to go back towards the back side of the patient. The retraction with the index finger of the non-operating hand, and the finger rests are intraoral, palm up, and the fourth finger on the incisal edges of the occlusal surface of the adjacent maxillary teeth. So maxillary anterior sextant facial aspect surfaces towards the operator. Operator position should be in front of the patient, and the finger rests are intraoral, palm down, and the fourth finger on the incisal edges of the occlusal or facial surfaces of the adjacent maxillary teeth. And if you are doing on the lingual side of the maxillary anteriors, then the operator should be on the 12 o'clock position of the patient, that is back side of the patient. The finger rests are intraoral, palm up, and fourth finger on the incisal edges of the adjacent teeth. conventional finger rest. And if maxillary left side of the patient's maxillary left side you are doing, then the operator's position should be side or back side of the patient. Then the illumination is direct or indirect, and finger rests are extraoral and palm down. And maxillary left posterior sextant, the facial aspect, backside or side position of the operator is seen, and finger rests are intraoral, palm up. And maxillary lingual aspect, left side if you are doing, then the operator should be in front of the patient. Intraoral and palm down opposite arch is reinforced. And maxillary left posterior sextant and lingual aspect, that is palatal aspect, the operator should be on the front side, and finger rest is extraoral and palm down. And again, if you are doing on the posterior sextant lingual side maxillary, then intraoral and palm up. Coming to the mandibular, if you are doing on the left side of the patient, then the operator should be on side or back. The finger rests are intraoral, palm down, fourth finger on the incisal edges of the adjacent teeth. And on the lingual aspect of the posterior side, left side of the mandible, then the finger rests are palm down. So this is palm down, and the fourth finger is on the occlusal surfaces of the adjacent teeth. And maxillary facial side in anterior teeth, then the front position of the operator is seen, and the finger rests are intraoral, palm down. Is whatever it is in mandibular, it is palm down. And facial aspect surfaces from the operator, mandibular anterior sextant, back position, that is 12 o'clock position, and intraoral, palm down. Whenever you do scaling and root planing, the shank of the instrument should be parallel to the tooth surface. The handle or shank should be parallel to the tooth surface. And mandibular anterior sextant lingual side, then the intraoral, palm down, and the fourth finger is placed on the incisal edges of the adjacent teeth. Mandibular right posterior sextant, it is intraoral, palm down, and the fourth finger is the incisal edges of the occlusal surface. And mandibular right side lingual aspect, then intraoral, palm down, so the same fourth finger is placed on the anterior occlusal surfaces of the adjacent teeth. So with this, the conclusion is scaling and root planing is one of the most effective ways to treat the gum diseases before it becomes severe. So proper instrumentation and chair positions helps the operator to complete the procedure without delaying, and also reduces the chances of future musculoskeletal problems to the clinician. So you don't have to lose teeth due to the periodontal disease. It can be cured successfully with the treatment. Thank you.